everybody, we're going to go ahead and get started. Disclosures are being worked out. So it is my pleasure today to introduce our guest speaker, Dr. Ben Handrick, who is coming all the way from Pennsylvania via the World Wide Web for us today. Dr. Handrick is a former resident of our PG1 and Oncology PGY2 programs here on the Augusta campus, so I'm very excited that he has agreed to come back another year to help teach this important content. I want to put a quick plug in for today's content. Febrile neutropenia, in my opinion, is one of the most important topics in oncology. And it's something that regardless of what type of oncology rotation, if you have one or future career, is going to really play a key role. And as one of the oncologic emergencies, it is an area where you can definitely make interventions that can save a life. So I'm going to pass it over to Dr. Handrick to get the class started. Thank you.
Fantastic. Thank you, Dr. Clemens, for the introduction. And thank you, everyone. I'm very excited to be talking to everyone about febrile neutropenia today. Like Dr. Clemens mentioned, I really think this is an important topic, regardless of your path of pharmacy, whether it be critical care, emergency medicine, infectious disease, ambulatory care. Febrile neutropenia is such a common oncolytic emergency, and really it's an area where pharmacists can have a huge intervention and truly can save lives. So I'm really excited to go through this with everyone today, but we actually want to start the class today with an so I believe there is a quiz live for the group, and when you go into the quiz, the password is antibiotic. No capital letters, just antibiotic. So you can go ahead and access that quiz this morning, everyone, and we'll give everybody about 10 minutes to go through that. Again, antibiotic, no capitalization. So is everyone accessing?
What was the password? We got disconnected.
It's antibiotic. My apologies, I guess we're having some technical difficulties this morning. So we're going to start everyone with a quiz this morning real quick, an in-class quiz. If you go into the website, the password is antibiotic. No capital letters, ANTIBIOTIC. We'll give everybody about 10 minutes to get logged in, go through the quiz. And I will give everyone a heads up when we hit the 1 minute mark. All right, everybody. So with that, we'll call it 10 minutes for the in-class quiz, and we'll go ahead and get started. So again, good morning, everyone. I'm excited to be talking to everybody about febrile neutropenia today. I do want to highlight that today's materials for our 1 hour lecture are posted to the e-learning site. So everyone should be able to go there to access the slides. I recognize that apparently we're having some technical difficulties today. So as we move forward through the presentation, if you can't see the screen for some reason, I will also kind of call out the slides as we talk our way through these patient cases to really highlight some clinical pearls and practice applying pharmacotherapy to febrile neutropenia. And additionally, this entire lecture will be recorded and then posted to the e-learning site later on today, potentially this weekend. That way everyone can have that to review as they prepare for the upcoming exam. So let's go ahead and dive into febrile neutropenia and apply some of the concepts that we've learned in the pre-lecture discussion. So the objectives for today are exactly the same. I do want to take a moment to pause real quick and open up the floor if anyone had any initial questions after reviewing the pre-class lecture. All right, so let's go ahead and let's jump in. The real goal of today's lecture is to have a conversation and discussion and really practice some of these principles that we learned. As Amber highlighted and I highlighted before, remember?
Bruno?
Best care possible.
Oh, wait, oh,
so let's go ahead and get started with case one. AB is a 60-year-old female seen in the oncology clinic after running a fever, which is 101.6 Fahrenheit, last night. She has a medical history that includes stage 2 breast cancer, which she's being treated with doxorubicin and cyclophosphamide, which is her chemotherapy regimen. She received that about 10 days ago. I've listed here some pertinent clinical and laboratory information, including blood pressure, heart rate, respiratory rate, so vitals, as well as some basic information from her CBC or complete blood count. So looking at this patient, we have a cancer patient presenting to clinic, has a fever. Looking at the white blood cell count, we have a concern that potentially febrile neutropenia could be on the plate given that infectious presentation. So I want to take a moment to let everyone's groups review. The first question is, what is her absolute neutrophil count, or the ANC that was discussed in the pre-lecture? I'm going to give everybody 2 minutes to go through and calculate the ANC for the patient. And then my second question is, what degree of neutropenia, if she has it, would you classify it? So we'll give everybody 2 minutes real quick in their groups, and then we'll ask for volunteers, and if there are no volunteers, then we'll start calling in groups. All right, everybody. Hopefully you got a chance to review with your groups there. Again, for those following along with the slide deck, we're currently on slide 4. So, do we have any volunteers that want to explain to the group what our neutropenic count is in terms of ANC, and also what degree of neutropenia we would classify the patient as?
420? 420 and severe.
Excellent. Does anybody agree or disagree with that?
Sarah, you agree?
We agree.
Fantastic. So for the first group that volunteered an answer, how did you guys come to that answer in terms of the calculations, and why did you classify her as that?
Excuse me? I used the equation.
Yeah,
What did you say? So I used the equation and
Yeah.
less than
5
500.
plus 30. You use the equation and she has less than 500.
Fantastic. So we put the equation here, we've highlighted some of the counts. One of the things that is important to call out is when you get anything less than 500, you're going to meet that severe criteria. And the classification is really important because that has been an area that has actually changed given some recent guideline updates. So actually last year when we presented this slide, there was some conflicting information between how IBSA and NCCN, which are two clinical governing bodies, described the depth of the neutropenia. So NCCN has the classical definition of profound neutropenia being an ANC less than 0.1 or 100. And it used to be that IDSA called out 500 of the threshold. However, we had an exciting update this past year where the Infectious Disease Society of America, or IDSA, and ASCO actually revised some of their classifications. And I want to highlight, as the group identified, that we actually now have essentially 3 criteria. We have neutropenia itself, then we have severe neutropenia, and subsequently we have profound neutropenia. So with our patient, she's 10 days out from the chemotherapy. So based on our pre-lecture discussion, she's in that nadir. Her counts are falling. Hopefully they'll be coming up any day now. But at least based on the current classification, her ANC using her bands and segs allows us to calculate her neutrophil population as a portion of her blood, and that allows us to classify her as severe neutropenia. So excellent work to everyone. I do want to highlight, particularly with the new, more cohesive definition of profound neutropenia, you're going to see this more commonly in cancer patients who have hematological malignancies. So we're talking to patients with leukemias and some lymphomas, so really those liquid tumors. Those patients who have solid tumors, I'm not saying that they can't become profoundly neutropenic, but that is not something that we would typically expect in their clinical care. So it's something to be aware of, that if you have a solid tumor patient who has really profound neutropenia, this is something where you may start to consider, do we really need to think about how to treat and manage this patient's care? So everyone did an excellent job defining the ANC and also putting out a potential classification. The other component of AB's care that we need to consider is, I've given you a lot of information about the cancer and the CDC, but what other information do you want to know about AB in order to help optimize her care in terms of both antibiotics and where you want to treat her? So what other questions would you want to ask? We'll give everybody about a minute to review in their group, and then we'll ask for some volunteers.
I tipped $15.
And for those following along on the slides, we are currently on slide number 6.
Yeah, you did a good job.
All right, everybody. Do we have any volunteers for what further information you want to request about AB to help optimize her care? Excellent question.
If she has any other comorbidities?
Excellent.
We would want to look at her renal and hepatic function as well.
Fantastic. We must be in a pharmacy class. That's some great suggestions and some really pertinent information. And I want to highlight here some considerations that you need to think about when you're dealing with a patient with febrile neutropenia, particularly in this case, because remember that AB we're encountering in the clinic. So currently we're in the outpatient setting. Often in the care of cancer patients, The outpatient clinic can be, it is not always, but is often separate from the inpatient unit. Therefore, it's important to really think about considerations with febrile neutropenia because it's really going to guide some of our decision making in not only what antibiotics we pick, but also where the patient is ultimately going to need to be treated in terms of monitoring. So some great suggestions by the group. Real shout out to the fungal, looking for fungal infections, but we'll table that discussion for our next lecture. But I want to highlight that knowing medical comorbidities is important, as that can help to highlight how critically ill your patient might become. Obviously, a patient with fewer comorbidities can be managed more efficiently at the outpatient setting versus a patient who has 5 to 6 medical comorbidities, thus their risk of decomposition is increased and requires more monitoring. I'm really glad that we mentioned hepatic and renal dysfunction. That's going to influence the choice and the doses of our antibiotics in a moment. I also want to highlight some things to consider is the patient's hydration status. If a patient is dehydrated, this is already putting them at an increased risk for decompensating in terms of conditions such as sepsis. So making sure that the patient can be, one, adequately hydrated via PO hydration, which is the patient drinking liquid on their own, versus a patient requiring IV hydration, which of course, when we have to hook up an IV line and infuse fluids, that will influence where our patient's care can occur. Additionally, we want to know the anticipated duration of neutropenia, because that will influence our decision-making process, and also the patient's performance status. Again, performance status is a cancer measurement of how well your patient is able to conduct activities of daily learning. Activities of daily living. So if a patient is walking about, is able to go for walks in the parks, has really no complaints, they would have a lower performance status, so 0 to 1, versus a patient who is terminal bound to the bed and can't get up and do anything, which is often a 3, with 4 being close to death itself. Again, patients who have a higher performance status would be candidates for being treated inpatient versus outpatient and really alter that risk stratification. Finally, for AB, based on all of these scenarios, as we called out in the previous question, with her underlying malignancy and treatment, she would traditionally be low risk for febrile neutropenia. Additionally, she doesn't have a lot of these medical comorbidities that were called out in the case. Thus, it would be appropriate for her to be considered low risk. But I do want to highlight with this case, even though a patient is deemed low risk for febrile neutropenia, that doesn't mean that they can't still develop an infection, such as in this example with AB. Though if you looked at her on day 1 of her chemo regimen, you would have thought she's a low risk for febrile neutropenia. This highlights that they can still develop infections. And so we do need to be vigilant about monitoring our cancer patients for infection, regardless of whether it's a solid or a hematological tumor. So strong work, everyone. So talking about risk stratification in terms of comorbidities, renal function, I've alluded to the guidance of whether patients need to be treated inpatient or outpatient, and additionally what initial antibiotics are selected. And I do want to highlight that the NCCN guidelines actually do call out a multitude of criteria that need to be considered. And if you look between these two classifications for high risk versus low risk, one of the things I would want to highlight is obviously on the high risk side, you're looking at your quote unquote sicker patients. These are the ones who have more medical comorbidities, who are anticipated to have more severe and prolonged neutropenia. The patients who have hepatic and renal insufficiency, and additionally the patients who have uncontrolled disease and have a multitude of other factors that make them look sick, as opposed to your low risk patient. And I oftentimes in clinic you'll hear people talk about a patient being quote unquote walkie-talkie. And what we mean by that is this is a patient who you're seeing in clinic who had a fever, but otherwise is sitting there in no distress, no trouble breathing, is able to adequately hydrate themselves, they have no nausea and vomiting. These are the low-risk patients in accordance with their anticipated risk for neutropenia, whom you could consider PO antibiotics because they are outpatient. They won't require the intense monitoring and administration of IV antibiotics. I additionally want to call out mucositis because mucositis is a common side effect of some of our chemotherapy. I've listed here grade 3, grade 4, which is just a criteria that highlights how severe it is. The higher the grade, the worse the side effect. The reason that this is called out under high risk is if a patient has grade 3, grade 4 mucositis, think about that. They essentially have ulcerations throughout their mouth and down their throat. They're not going to be able to swallow PO antibiotics, and this is why it would be important to classify them as a high risk so that they can receive IV antibiotics to achieve appropriate pharmacokinetic and dynamic parameters with their antibiotic. The last thing I've listed here is the MASC score, which is a risk index which can be used to classify patients based on their ability to receive treatment in patient or outpatient, and also here at the table. And I want all the groups to take a moment to go through and use the math to determine what AB's score would be. So everybody take a minute to review your group, and then we'll ask for volunteers.
Sarah, what'd you get?
24.
Okay.
What'd you get?
I got 26, but I was just winging it.
24. She just is over 60 or not
She
over
is.
60.
So she's 60, so do you count that?
You're gonna be less than 6.
Okay, so not equal.
Wait, are you on the airport right now?
This is 24, okay.
Oh, my flight's not full.
Bye.
Bye.
Be careful.
Bye.
Go to, are you gonna be there, when are you coming back? Tuesday. Oh, so you're not gonna be there to see you next Tuesday? Or girls night out?
I'm gonna
Yeah, take some pictures for me, drink. Have good. Please. Bye.
All right, everyone, hopefully you had a chance to discuss that in your group real quick. Again, for those following along with the slide, we're currently on slide 8. So, what did the groups calculate AB's MASC score to be?
24.
We're just gonna use 12 questions, I guess.
22.
Oh.
Excellent. Anyone want to agree or disagree with that?
That was Maddie, I can't tell if she's wrong.
I put 24.
Okay. Anyone agree or disagree with either of those two answers?
Go, Sarah.
We agree with 24?
Did anyone get greater than 24?
Oh, I got 26 first, but then I took it back down. Is this your 26? Is that
And
right?
reciprocally, did anyone get less than 24?
Oh, well, that, your two said they got 22.
The reason that I'm calling out these variations between 23 and 24 is looking at the MASH criteria, we can see a lot of those underlying principles we just talked about in terms of risk stratification for cancer patients. Again, we're looking at hydration status, we're talking about the underlying malignancy, we're looking at some comorbidity information, ensuring the patient is not septic by assessing blood pressure. The one caveat with the MASH score is that while it is objective, there is this one subjective component which requires the clinician to classify the symptoms as absent to mild, moderate, or severe. And one of the reasons that you can see such variation in MASH scores is particularly this mild to moderate. You can see that there's a difference of 2 points. And that 2-point threshold can often push patients over that 21 score threshold, which determines some high or low risk. And so I'm not surprised that the group saw such variability, and that's one of the reasons that we did this exercise. The real point that I wanted to highlight for the group is that this is a validated method to really help with that risk stratification. Many institutions don't necessarily use the MASH score, but it's important from a clinical perspective to keep this methodology in your mind when working with your medical team to determine is a patient high risk versus is a patient low risk. And reciprocally, how do we treat them based on that? So, we're continuing along with AB. We've talked a lot about her neutropenia. We've classified her as low risk. Based on our classification, we're potentially thinking, maybe we could treat her in the outpatient setting. So my question to the group now is, what febrile neutropenia regimen would you recommend in terms of antibiotics? We'll give everybody about a minute to work on this with your groups. And again, for those following along, we're currently on slide number 9.
He knows people.
All right, everybody. Would anyone like to volunteer what they would recommend in terms of antibiotics to treat AB's febrile neutropenia?
Ciprofloxacin and Augmentin.
All right, I agree with that. What dose would you recommend?
You could use Cipro 500 by mouth every 12 hours, and then Augmentin 875 milligrams by mouth Q12.
Fantastic. And I do agree with your dosing there. The big take-home message here is that since AB has been classified, she was initially low risk when she was being treated based on her malignancy and her chemotherapy. She presents to our clinic with febrile neutropenia. We clinically assessed her and did some stratification. We actually conducted the MAC score, and so it is appropriate to consider oral antibiotics. And we're currently on slide number 10. And what I want to highlight with this information is there actually are a multitude of right answers here based on some of the evolving IDSA criteria, which again is one of those clinical governing bodies, and additionally NCCN, which is more of a hematology oncology clinical governing body. The group mentioned 500 PO Q12. I completely agree with that. I will highlight that with ciprofloxacin, there is actually some emerging data on there that's very promising to use the higher dose, which is 750 Q12. Now, the reason for this higher dose is there's been some evolving data that it gets better penetration in terms of getting to the various compartments of the body. This is important particularly for febrile neutropenia when you don't necessarily have a source. So something to consider with your team and also based on your formulary and what's available to you at the time. I want to highlight with ciprofloxacin that you often and need to augment that with amoxicillin clavulanate or Augmentin. The purpose for this is Cipro itself has some pertinent gram-negative activity and some potential activity against Pseudomonas, we will call it, but it is lacking on the gram-positive spectrum. This is where amoxicillin, Augmentin becomes more important because it helps to supplement some of that gram-negative deficiency that's seen with ciprofloxacin. If your patient didn't want to take multiple medications, it would be appropriate to consider levofloxacin or moxifloxacin alone. Again, things to consider with either of these agents are the dosing components. With levofloxacin and moxi, it's once a day. Additionally, with moxifloxacin, I'll highlight that you're getting a little bit more gram-positive coverage, as well as some anaerobic coverage. So these two single agents can be used. Currently, NCCN does classify Cipro plus Augmentin as a category 1, and actually recently adopted moxifloxacin as a category 1, with levofloxacin representing a 2A recommendation. So what that means is essentially the data is not necessarily as strong, but all of these agents would be correct choices. Some things to consider though, using these oral antibiotics, you have to ask the hard questions. Can the patient tolerate PO? Also, is the patient close enough to the clinic and have the appropriate health literacy for monitoring? Of course, we're going to give an antibiotic, but we need to make sure it's effective. If our patient lives 2 hours from home and doesn't know how to use a thermometer to report a fever, this is a patient who may not be a candidate for outpatient treatment. And this is a case where admitting them to the inpatient unit may be more effective and safer for the patient. The other component that I'm sure this group is innately familiar with based on your ID lectures is you have to know your local susceptibilities. And so your ID colleagues, and particularly the antibiogram, becomes your best friend when treating outpatient. If you're practicing in an area where you know that your fluoroquinolone resistance is very high, this may not and should not be the right answer. Again, though the clinical guidelines do recommend this as a high priority evidence-based recommendation, it's very important to know that epidemiology at your local institution. That way you can really optimize your care. Excellent, everyone. So let's say we proceeded with that and we used the oral treatment of antibiotics. I do want to highlight that while for AB this is appropriate, it may not be the right answer for everyone. The NCCN actually does call out some explicit social criteria, which are listed here. The big overarching message is patients need to have a caregiver at home to support them. That's important because if a patient becomes septic at home and they're by themselves, they may not be able to call and get help. Additionally, they need to have a mode of communication to be able to communicate with both the clinic and to call for 911 help if something would occur. Most institutions follow this NCCN guideline and call out a 1 hour radius around the medical center or a clinic practice. So those patients who live more than 1 hour out, there's concern treating them outpatient because if they would become more septic or they would continue to become ill even while on oral antibiotics, since it would take them more than an hour to get to the clinic or to get to a hospital, it could delay the administration of antibiotics. Again, referring back to our ID knowledge, we know that time counts in sepsis, and this is why this 1 hour threshold can preclude patients because it puts them outside that safety radius. And additionally, as we talked about before, the patient needs to be able to tolerate PO medications in terms of swallowing and not having any nausea and vomiting that prevents the oral administration and bioavailability. And lastly, we need to ensure that the patient did not receive prior fluoroquinolone prophylaxis. This is important because if a patient was on fluoroquinolone prophylactically and then they develop a fever, obviously the prophylactic fluoroquinolone may not have been treating the underlying organism. So we would not want to treat with the same antibiotic, but would want to use an alternative agent to help treat the underlying infection. Excellent. And so we give AB her oral antibiotics, and let's say that we proceeded with giving her the ciprofloxacin plus the Augmentin. What are some education points as a pharmacist you would want to provide the patient in terms of both the medications and the disease state for AB, particularly focusing on the monitoring, given that we're going to treat her outpatient? We'll give everybody about a minute to think in their groups, and then we'll ask for some volunteers. And my apologies for those of us who are following along with the slide deck. We're currently on slide number 12. any volunteers in terms of education for medication for and disease state? All right. How about group number 4? What would you guys want to educate AB on for this oral antibiotic regimen?
We would want to educate on the importance of taking it as it's prescribed and describe the potential problems she could face if she didn't take it, and also to educate or tell her to monitor her fever, and if it's persistent after she's been taking her antibiotics as appropriately, to come back, because it may not be working and she might need IV antibiotics.
Excellent. Some really good points to call out, particularly focusing on the next steps in case that her condition would worsen. Excellent. Do any other groups want to volunteer what they were thinking in terms of education points?
Take the Augmentin with food.
Excellent. Excellent. Very important to highlight some of those pharmacodynamic, my apologies, kinetic and dynamic perspectives. How about any education on the fluoroquinolone in particular?
Don't take with dairy products.
Excellent. We're always concerned about the pharmacokinetic properties in terms of bioavailability. So we need to avoid dairy products, antacids, multivitamins, those kinds of agents which can chelate the fluoroquinolone and prevent the absorption. Very important to educate, because patients are often not aware of this, and it would be a shame, and it definitely happened, where a patient is unaware of this and they're being treated outpatient, and you can see progression of the infection due to the non-effective blood concentrations of the drug related to those absorption barriers. Excellent. And the group has gotten a lot of this. I do want to highlight some education points here. The group mentioned for the Augmentin taken with food, I completely agree. We also want to make sure that with both of these agents, we talk about the risk for diarrhea. That's something that can be anticipated with these antibiotics, but is also something that we want to keep an eye on from a disease state perspective, because that could give us some evidence about a source of infection. So we want to ensure that patients report that. Tendinitis is important to discuss with patients given the risk with fluoroquinolones, and also want to highlight photosensitivity. It's one of those things, particularly back down south, where being out in the sun, we want to make sure that our patients are aware of that risk. And if they're going to go outside, they need to wear a hat or wear sunscreen and try and limit as much direct sun exposure during periods of high UV radiation. In terms of febrile neutropenia, I think the group called out in an excellent fashion that we need to make sure the patient knows to monitor for fevers. Patients should be given or ensure that the patient has a thermometer at home. It's one of those things that you wouldn't consider, but many patients don't. So they need to ensure they have a mode to monitor for fevers. Just saying that they feel like they have a fever is not appropriate. Additionally, we need to ensure they're not empirically taking NSAIDs around the clock. The risk being that empiric or prophylactic NSAIDs could mask a fever, which, as we talked about in the pre-class lecture, could be the only sign or symptom of the infection worsening. And lastly, as the group mentioned, we need to ensure that if the infection gets worse in terms of fever, malaise, the patient has trouble breathing, nausea and vomiting, diarrhea, we often tell our patients, if anything changes for the worse, call us back right away, because we may need to reconsider our treatment strategy. Excellent, everyone. Excellent, excellent. And so our case with AB has really highlighted the outpatient or ambulatory side in terms of looking at patients, doing some stratification, providing an outpatient oral antibiotic regimen, and then the monitoring parameters. So let's switch over now and move to our next patient case. We are now on slide 18, and, oh, no, my apologies, we're on slide 13, and we have our new patient, MG. So we're going to shift over here a little bit Let's talk about MG, who is a 60-year-old female. She is being treated with docetaxel and etoposide for small cell lung cancer. Now, she's being treated outpatient, which the majority of our ambulatory regimens for solid tumors and even some liquid tumors are. And she calls the clinic reporting that she has fever, nausea and vomiting, and persistent fevers. She does have a thermometer at home, and she's calling to report that in. But based on this information, the patient was encouraged to go to the ER where they documented several fevers on hand. The fevers are listed there in Celsius, and additionally, they did conduct a CBC and identified, based on that ANC, or absolute neutrophil count, of 0.32 or 320, she would be neutropenic. She would technically be severely neutropenic. We've listed her hemoglobin and platelets there. So the physical assessment and patient interview determined the patient has a wet cough, and the patient additionally admits to a history of urinary tract infections. The provider does do an inspection of the central line and reveals no erythema or tenderness at the access site. This is an important component because the majority of our cancer patients have a central line. This is important for chemotherapy because it allows for safe administration. The counterpart to that is the central line is a foreign body. Therefore, as I'm sure that you've learned in your IV courses, this puts them at a high risk for infection due to seeding and penetration of our protective barriers in terms of skin. So, looking at this information, let's say that you were on your ER rotation and you're working with the medical resident. This patient presents with what's looking like febrile neutropenia, and they do have this initial information. My question to the group is, what further lab work would you recommend the medical resident to order so we can really optimize this patient's care? We'll give everybody a minute and a half to 2 minutes to review that in your group, and then we'll ask for some volunteers.
They had them on sale for Mardi Gras. So I got 2 dozen for $14 instead of 2 dozen for $18.
Dang, that's a good deal. I had to talk to someone the whole way here. I called my mom and I was like, hey, I just want to talk to you while I drive to make sure I don't, pass out again. I just went to, one of those LabCorp places. But yeah, I just remember asking her, I was like, are we almost done? And then I remember waking up on the floor. There was ice behind my neck, and that felt really good. So. I'm the worst baby.
Yes.
No, I don't want another.
A donut hole?
No, they're holding one.
All right, everybody. Would anyone like to volunteer what labs they're recommending for medical resident to really optimize someone's care?
Did you say that?
We said a chest x-ray, urinalysis, central line culture, blood culture, repeat CBC with diff, BMP, and CMP.
Excellent. Very comprehensive. Does anyone want to add or subtract to that recommendation or have a differing of opinions?
You could do a sputum culture.
Excellent. I like it. I like it. Fantastic. And the group called out some really good labs here. And for the slide deck that you're following along with, the slides 14 and 15 are blank. that allow you to document some of this information that we're going to discuss. I agree completely with that first group. It's very important to get some of these comprehensive laboratory work to look at the hematological component in terms of their cell counts, particularly their ANC, to perform a complete metabolic panel. I will add to the group, this can change from institution to institution. One of the differences between a complete metabolic panel and a basic metabolic panel is the CMP will have liver function included. Again, when you go to your rotational experiences, that's one of your questions I would ask your preceptors. But a CMP is a little bit more comprehensive in terms of looking at renal and hepatic function, thus the name complete metabolic panel. The BMP focuses mainly on some of your renal function and your electrolyte markers. So I do agree with the group, getting a CMP is important. We need to know that renal function, and we also need to know the hepatic function, because with some of our involving antimicrobial agents, there actually is some involvement with hepatic function. This is particularly important when it comes to antifungal agents, which we'll table for this lecture, but there's something to tuck in the back of your mind, because that's going to come back when we talk as a group in our next class. One of the other lab parameters I would throw out there is lactic acid. So this is a biological surrogate marker that can be used to trend infection severity. It's also important from a hematological perspective for those patients who have liquid tumors, because it also tells us a little bit about how severely ill the patient is. Remember that lactic acid, the initial number, doesn't necessarily have to meet any threshold to be severe. Although if it is high, this will be something that causes concern and something that you want to monitor. What's more important with lactic acid is that it's trended over time. This becomes particularly important for septic patients, as it helps to guide how patients are responding to therapy. Additionally, I will call out, it's not put on this slide, but procalcitonin could be something that you may consider based on your institutional practice, and I'll defer the group to your infectious disease lectures, or if you have interest in learning more about it, there's a lot of interesting data on the use of procalcitonin to help guide some infectious disease decisions. Additionally, in terms of laboratory work, the group called out cultures, and I'm so glad that we called that out, and particularly that we picked out the chest x-ray. Excellent work. So I want to talk about the blood cultures first. You always need blood cultures. The reason for this is we're trying to get a baseline. As we discussed in the pre-class lecture, often with febrile neutropenia, we may not have a clear source. We need to ensure with blood cultures that we don't have a potential brewing bacteremia, which could lead to sepsis. And we need to ensure with our cancer patients that we're getting a culture from the central venous catheter. Again, these implanted devices are foreign objects that are highly prone to infection. So at a minimum, you always need at least 2 blood cultures, at least 1 from the central venous catheter if it has 1 lumen, and additionally a peripheral stick as well. I'll highlight that with central venous catheters, this is something I'm sure you'll discuss on rotations as you go through your athlete experiences. They can have multiple lumens or multiple lines in the catheter. So there can be a triple lumen, which means there's 3 lines in the catheter. It can be double lumen, which is 2, and it can be single lumen, which is 1. If you would have a triple lumen central venous catheter, you would need 1 blood culture from each lumen. You additionally would need 1 peripheral stick. This is why the threshold of 2 cultures as the minimum needed is always pertinent. And this is an area where as pharmacists you can really make some recommendations and support your medical colleagues. The group called out in terms of chasing an infectious etiology, doing a chest x-ray, completely agree for this patient. You'll notice in the presentation that I highlighted at the top, I do want to highlight that a chest x-ray is not always empirically recommended. My guess is as you go on rotation, you'll often see a baseline chest x-ray done as a precautionary measure, but the guidelines don't say that it's mandatory 100% of the time. This is something you would really want to consider when you're concerned about a pulmonary infection. And very high kudos to the group with the sputum culture. Hopefully with that wet cough, we can try and culture some kind of organism that we can guide our therapy. The last kind of culture I would call out is doing a urinary analysis and urine collection. You'll remember for MG that she has a history of recurrent UTI. At this initial presentation in the ER, we have a really broad scope. We're trying to match, again, disease, potential sources of infections with monitoring parameters. And I do think it's appropriate, since she has a history of UTIs, to do a UA and also do a urine culture to ensure that we can rule out all infectious etiologies. So strong work, everyone. So, we send away our blood work, we send her that chest x-ray, and we're getting our blood cultures. And this is some of the information that starts to come back in our electronic medical record. So my question now goes to the group for MG, based on this initial laboratory information and that clinical assessment, what febrile neutropenia regimen in terms of antibiotics would you recommend for MG? Remember that she is in the emergency. I will give everybody 3 to 4 minutes to review this, since there's a lot of information here, and then we'll ask the group for volunteers.
Guess I could get my computer out. I really feel like I should lay down, but that's okay. What's the quiz? Huh? Was the quiz hard?
I thought it was, because that was the stuff that I did not look over.
Was it any of the, like, that paper we were supposed to read?
The paper, you were just supposed to look at the figures and stuff, and that was all in the PowerPoint.
Because I didn't look at that, but I read through the PowerPoint.
Yeah, the paper was just, he put the stuff from the paper in the PowerPoint.
I skimmed through the PowerPoint.
Oh, I like your nails. I like that
you.
color. Yours are very nice too, Aaron.
I know.
This like gray like cloud over me for like the rest of the day whenever I pass out. It's the worst.
You ever passed out?
Multiple times.
I pass out all the time.
In high school, my blood sugar used to drop like all the time, and my vision would just go black.
And your vision would just go black. That's scary.
Yeah. I didn't know what was happening the first time until like, if you buy a teacher's like, your blood sugar's low, get a Coke. And she like got sugar in me, and that was fun.
Yeah, that's why I just ate that donut.
That's why I was thinking of the donut.
I know.
And I have.
You're a sweetheart.
When you said you passed out, I was like, I wonder if that's at the office, or if she was just like somewhere and passed out.
No, yeah. I just like, I woke up and they were like, Jenny, do you know where you are? And I was like, no. And then, that was the first time. And the second time I woke up, I was on the floor. You know? But there was ice behind my neck and it felt really good.
You tried the Vans challenge?
What's the Vans challenge?
To see if your Vans land right side up every time you throw them?
No. You throw them and you look like...
You throw them and they're supposed to land right side up.
Is that just because they're heavier on the bottom?
I think so.
Vans are the most comfortable shoes on the planet.
Crocs are
They
apparently
have no
supposed
arch
to do.
support.
They don't, but like I have super high arches, and I feel like I
Keep wearing Vans and you'll watch them fall.
I feel like that's something I look for in shoes, but Vans, like they're so comfortable to me for some reason. But like in all my tennis shoes,
I want to see if this is a real thing or if it's just a snap.
don't judge me. I don't wear socks with my Vans.
It was like double price.
I just gave it a little spin.
I'll get it so you don't have to stay.
Kick it back to her.
All right, everyone,
Just chuck it
give
across the
everyone 30 seconds more to work with you.
Where'd it go? Oh, it did land right side up.
On my foot.
Yeah, no, I used to wear Vans to like work. I don't know why, but Also, I had makeup on this morning, and I woke up and they were like wiping these wet paper towels across my face. I was like, I want to be like, no, stop! I just have makeup on. They took all my makeup.
All right. Would anyone like to volunteer the recommendations for antibiotics for MG? How about group number
Wait, does
14?
every shoe do that?
What were you guys recommending?
This is just everybody trying it now because
What about Converse? They're like the same thing as Vans.
I think 7.2 grams IV every 8 hours would probably be okay. But we, of course, maybe have to just, go along and make sure that their creatinine clearance is stable, because we would need to really dose adjust that if it begins to change in any way.
Yeah, that's what I did. I just flipped them.
Fantastic. How about group number 7? What did you guys recommend for MG?
Them's cool. That's crazy. I've never even seen that.
We actually get the same thing.
Do you have Vans?
Excellent. So some things that everyone's thinking about. So we have a patient presenting at the door, obviously a high risk for leukemia. We have potential sources here. Keeping in line with the guidelines, I agree with both of the groups that we want to consider using an anti-pseudomonal beta-lactam. That's very, very important for a high-risk patient because of the high prevalence and concern for these aggressive gram-negative infections. So I highlighted on this slide some potential recommendations. And I do want to call out to the first group, I completely agree. We do need to be very cognizant of renal function. On the previous slide, I noted, you'll note the patient's serum creatinine was 1.5 and their BUN was 40. This starts to point out that conversation that, there probably is an underlying acute kidney injury. And when you actually calculate Cochrane Gulf, will come out to get a creatinine of 41.5. So I would recommend, based on the package insert guidelines for febrile neutropenia, 2 grams of cefepime Q 12 hours. What I will call out, for example, the institution I work at, we actually used 1 gram Q6 as our initial therapy because it targets a longer time above MIC. What I will highlight is, in this case, you want to make sure that you pick an agent that has anti-pseudomonal activity, such as cefepime for the dosing, and then additionally, you dose adjust the medication for this renal function. And that's important because a lot of patients, when they initially hit the door, will be so sick that they have a little AKI building. Additionally, since we don't have a source of infection, we need to empirically start with broad-spectrum antibiotics, which is why we need these anti-pseudomonal agents that have a very large gram-negative and some gram-positive coverage. You'll note that meropenem is listed here because it is on the guidelines, but I will call out that it is not an appropriate initial therapy in the majority of patients. This would be reserved for patients who have a significant history or very multi-drug resistant organisms, where you would need that heart attack. So strong work, everyone. I agree with getting that anti-pseudomonal on board. And let's say we do that, but overnight, the patient continues to have persistent fevers, and you start to notice a tenderness around her PICC line, or the central venous catheter. When the nurse goes to change the coverings, they report a virulent, fast-smelling liquid. On rounds, the PA is called by the lab, and they're notified that gram-positive rods and clusters are growing in both blood cultures. And we want to highlight the lab notes that the fourth culture, that central venous catheter, grew 2 hours before the peripheral culture did. Lab values are listed there. Her serum creatinine is getting better with some hydration, and the API is improving. But based on this new information, what would we want to do to modify MG's febrile neutropenia antibiotic regimen? We'll give everybody a minute to discuss in their group.
I have a question on Athens.
Dang.
Yes, ma'am.
Why don't we cover for MRSA empirically?
And by this time Alicia was done sitting
A
next to her, she was
fantastic
like,
question.
mine, did
Do you mind? Can I table that for literally 1 or 2 slides, and I will come back to that.
We called the other guy over there, and the other guy like.
All right, thank you though. I
went back
definitely
on
will
his
address
little
that.
cart, shoved it in his face. He was like,
Actually,
"Oh,
the very
beat
next
top
slide.
code, dude. Like you can't just use it."
Oh, no, I misspoke.
That's crazy.
Then
Was
he
it?
filed
Did
it
he
all
like give you a
down again.
discount?
No.
Give me a few more slides and we'll get back to that. But we'll give everybody a minute here to review what we would want to do in this case,
Then he
and we'll
filed
learn
it
how to
down
hit
again
there.
and put a different top coat on.
Wow.
Then I cured it, and then he gave me a nice manicure.
Yeah. No, your nails always look really good in here. Because like your natural nails, like your nail beds and everything are very perfect, and mine are all jacked up.
Yeah, I kind of wondering if I should regret getting
All right,
it because my
everyone,
nail
and
beds
in the interest of time,
Well, SNS
I will go
doesn't mess
through
up
this
your
one as an
nails that
example. But what we need to
Like,
highlight here is,
nails
you know,
are
we
really
have our
strong.
anti-subliminal
When I
cepapine,
take
but
SNS,
as our
I
colleague
like
just
that,
mentioned,
like,
it
sometimes
doesn't
the
have
top
the
layer
greatest
will peel,
gram-positive
but
coverage against
it's like a problem with
gram-positive
mine
rods and
because they're really
clusters,
brittle.
which is starting to
And they're,
hint
like,
at some kind
good
of
nails,
staph
so I don't think
infection.
it'll be a problem.
So one of the things that we need to consider
I need to go get
here
mine done.
is that our
They're
patient
going on
might
like 2 or
have,
3
and likely
weeks.
does have,
Really
a
bad.
central line
I want to go
associated
measure it. She
bloodstream
said she
infection.
thinks it's
And this is
engagement
often
season.
called a CLABSI. What the
So she said she's
giveaway
getting
for this
them done
indication
next.
is
That's
that
hilarious.
the patient
And
has the
exciting.
blood culture pop or become positive in the culture from the line first, followed by the peripheral blood culture becoming positive about 2 hours or 120 minutes later. This is called the differential time to positivity, and this is classical for a central line associated bloodstream infection. So as our colleague just noted, this is a moment where we definitely want to broaden coverage and get vancomycin on board. We follow your traditional PK guidance, probably a 20 to maybe 25 mg per kg loading dose based on your institution, and then therapeutic drug monitoring to achieve a maintenance dose with a trough targeting 15 to 20 before the 4th or 5th dose. Additionally, we want to make sure that we keep an eye on these blood cultures because now that an organism grew, hopefully in 24 to 48 hours, we'll have susceptibilities to de-escalate antibiotics. So to our colleague from Athens, fantastic question. I like it. And the reason that we don't use vancomycin in everybody up front is because looking at epidemiological data in terms of pathogens and their susceptibilities, gram-positive organisms, while they come and go, empiric MRSA coverage is often not necessary. And so the guidelines actually specifically call out the patient populations or the clinical signs and syndromes where you should consider vancomycin empirically. What you'll notice here is skin and soft tissue infection, catheter-related infection, pneumonia, gram-positive organisms. These are all things where, and even mucositis, due to some enterococcus, which could be penicillin resistant. These are all things that kind of scream gram-positive organisms. And it's in these cases where you would have high concern for gram-positive infection, particularly MRSA, that empiric vancomycin is important. One of the key principles of febrile neutropenia is start broad and then scale back. The one component of this that I will call out is sepsis. And with sepsis or hemodynamic instability, we often add the vancomycin because since the patient is decompensated, we're kind of throwing everything at them to try and stabilize. And with febrile neutropenia, that's really the underlying story, is you start at a threshold that has anti-pseudomonal coverage, focusing on gram-negative, because remember, with anti-pseudomonal agents, they target Pseudomonas and other gram-negative infections, which are very fast-growing organisms. They can often be very detrimental to patients. Then if we need to, we can expand our coverage greater by adding vancomycin, or if the patient stabilizes and we have sensitivities and susceptibilities, we can de-escalate and target the organism. So a really great question. I think the take-home message is, for febrile neutropenia, based on the current data, empiric vancomycin in everybody up front is not appropriate at this time. But as a pharmacist, we can help to monitor this and help to enforce that IV stewardship by keeping these indications to add bank in the back of our mind. To our colleague from Athens, does that answer your question about vancomycin?
Yes, thank you.
No problem. Very, very good observation. I like it. All right, so definitely appropriate to start vancomycin in this patient. And to continue on the conversation about central venous catheters, I've listed here some of the information that we've highlighted thus far. Again, it's a foreign object. We've really discussed some of this throughout our conversation. I do want to highlight that if you start to grow some of these pathogens that are located on the right-hand side, because the central venous catheter is a foreign body which can allow for seeding, it may be pertinent to remove the catheter. And I've identified some organisms on the right-hand side of your slide where you would want to consider pulling out that line. The issue with taking out the central venous catheter is a procedure that's occurring in patients who are often thrombocytopenic. And so this can become a risk-balance discussion on the patient's care. And I want to highlight in particular, there are IDSA-specific guidelines on catheter-related bloodstream infections. We don't have time to go through all of this today, but I do want to reference to the group. This is something to consider as you do your workup for patients with febrile neutropenia, particularly if they have a central venous catheter and have a bacteremia culturing some of these agents listed here. So, following Envy's case, let's say that there are susceptible, my apologies, let's say her susceptibilities return and they reveal MSSA. So we dodged a bullet, it's not MRSA. This allows us to de-escalate based on susceptibility to cefazolin or ampicillin. And the decision was made to pull the Mediport or central line because it was that Staph aureus organism, which is very sticky, quote unquote. It has a high tendency to accumulate on the line, which is why we need to remove it to prevent seeding. So for this case, she received nacicillin for 4 weeks from the first negative culture per the IDSA and NCCN guidelines. And additionally, a transthoracic echocardiogram was performed to rule out endocarditis. Discussed more in those guidelines that I mentioned, but whenever you have these bacteremias, particularly with foreign bodies, it's important to make sure that the organism is also not seeding in the heart. This can lead to endocarditis, which I'm sure you've discussed in your IV lectures. For her, chemotherapy was delayed until she was stabilized, and based on her regimen, about 4 weeks was when the next line of therapy was due. And additionally, based on our pre-class discussion, I want to highlight she was receiving docetaxel, which is one of those agents that actually has data supporting primary prophylaxis myeloid growth factors, such as filgrastim. Definitely in a case such as this, since she had a significant infection, using that prophylactic growth factor will be important moving forward to help prevent future infection. Fantastic work, everyone. So let's keep moving through this. On this, my apologies, everyone, the computer's jumping on me here. On this slide, I did want to do a brief call out about primary prophylaxis. For the majority of patients we've talked about so far, they've been solid tumor patients. And remember, in solid tumor patients, because we don't anticipate, based on their chemotherapy, having prolonged, profound neutropenia at baseline, we often don't give them primary prophylaxis. Patients who have hematological or liquid cancers, they're a whole other category. And because their therapies often do cause anticipated, prolonged, and profound, it's a part of their therapy that we actually associate as standard of care for occurrence. These are patients where it has been recommended based on the guidelines to give prophylactic antibiotics such as Levaquin or ciprofloxacin. The idea being the prophylactic antimicrobial can help during these periods of neutropenia prevent infections. And so this is a common occurrence, and if you work in a hospital or institution that has leukemia patients, this is something you commonly will see during that neutropenic state. So something to be aware of, particularly as we move on to our next case. So we have AG, who's a 65-year-old male, admitted to the hematology unit and was diagnosed with acute myeloid leukemia. I've listed some information there in terms of their cytogenetics. Would not ask a question like that on an exam. This is more of an example of what a real patient might look like. We're focusing in primarily on the antibiotics for febrile neutropenia. So this patient received chemotherapy and is now on day 10 of that regimen, which, remembering some of our information about nadir, we're starting to get near where that neutropenia can occur, and AG spikes of fever, 38.5, so very significant. We pull some lab work, and the white blood cell count is so low that we can't even calculate an ANC. And this is actually very common for leukemia patients. And again, highlights how for these patients with liquid tumors, particularly leukemias, this is an anticipated consequence of our therapy and why we need to be ultra vigilant for infections. I've listed some information there in terms of cell counts, the complete metabolic panel, and I've highlighted our creatinine clearance. The team does get blood cultures with 2 sets, and physical exam reveals no clear source of infection. Highlighting for this patient, they were on prophylactic fluoroquinolones, levofloxacin, again associated with these leukemia patients to help prevent infections, but despite our best intentions, sometimes they still develop infections. And so based on this case of febrile neutropenia in a 65-year-old male with AML who is currently severely, profoundly neutropenic, what febrile neutropenia regimen in terms of antibiotics would you recommend? We'll give everyone 2 to 3 minutes to discuss in their group, and then we'll ask for some volunteers. All right, everybody. Would anyone like to volunteer their initial febrile neutropenia regimen that they would recommend? How about group number 10? What did you guys recommend for AG?
We said that meropenem is appropriate, but either cefepime or Zosyn would be more appropriate at this time.
Excellent. Couldn't agree more, actually. And so as we go on to look at what we would talk about in terms of initial recommendation, I think you're spot on. So we can follow the guidelines as we've discussed thus far and in the pre-class lecture. We need that anti-pseudomonal beta-lactam monotherapy, broad spectrum focusing Pseudomonas, given it's an aggressive gram-negative organism in this healthcare setting. Cefepime and Zosyn would be appropriate answers in my mind. I still would hold back on the meropenem. Note that in this patient, I didn't identify in the history, the patient's history, an occurrence of multi-drug resistant organisms. That's really going to be your key for when meropenem or a carbapenem would be more appropriate. Again, those patients who have a history of MRD infections, the reason we may not want to fool around with cefepime-rososine is because particularly if it's a KPC organism or it's Acinetobacter, some of these agents may not be effective. And remember, for infections, time equates to mortality. So for this patient, since we don't have that multi-drug resistant history, to make our ID colleagues happy and to also promote antibiotic stewardship, I think cefepime-rososine will be a more correct answer, at least at this time. So you go to make recommendations to your team, but alas, you discover that they've already started vancomycin overnight before you could get involved. So the question I would pose to the group is, we've discussed that empirically starting vancomycin is always not appropriate, but now that the vancomycin is on board and the patient has Defer-Vest, what would you recommend to the team in terms of a duration for the vancomycin? Give everyone 30 seconds to discuss that real quick, and then we'll ask for volunteers. All right, so what would people recommend in terms of vancomycin for duration, or how to handle the addition of what may be an inappropriate vancomycin?
Oh, yeah, Defer-Vest.
How about group number 2? What would you guys recommend, or what are you thinking about? Number 2?
We can keep the bank for 48 hours and then reevaluate.
Couldn't agree more. Fantastic recommendation and right in line with the guidelines. So I want to call out, as we've discussed already, empiric vancomycin is not supported, and there's data that shows that empiric vancomycin doesn't impact mortality. Again, in terms of antibiotic stewardship, we don't want to generate gram-positive resistant organisms by overuse. The guidelines specifically call out that you can keep vancomycin on for 48 hours, but in the absence of microbiologically confirmed gram-positive growth, vancomycin should be discontinued. And I think that's a fantastic recommendation for AG. While this slide and the guidelines are very straightforward, this is one of those topics that is often difficult to apply to clinical practice. It's very hard when you have a critically ill patient who gets better on antibiotics. 48 hours later, nothing gram-positive grew, but the patient is clinically doing better. Often it's difficult and there's some hesitation to remove the vancomycin. However, to be good ID stewards, we should follow these recommendations and encourage our medical colleagues to do the same, which is taking that vancomycin off if within 48 hours there's no source of infection, which can be very readily attributed to a gram-positive organism. Fantastic, fantastic. So let's keep moving for the sake of time. And for AG, you got the vancomycin off, the cefepime remained on, and you actually go off service. But then 2 weeks later, you're back on service again, and AG is still there, recovering from the chemotherapy induction, but the patient is still on cefepime 2 grams. That's day 14 of antibiotic therapy. The medical resident asks you if AG still needs to remain on cefepime because the IV stewardship team has been paging them. And I've listed some labs information here in terms of ANC, blood counts, creatinine clearance again. The Patient is afebrile, patient's relatively is stable, and they've never grown anything in the blood culture or could identify any source of infection. So my question to the group is, what antibiotic duration would you recommend to the resident for cefepime for AG? We'll give everybody a minute to review this in the group. And my apologies for those who are following along. We are currently on slide 26.
As we did Savannah, well, they couldn't, I guess they couldn't see earlier.
All right, any volunteers for what duration they would recommend?
Would you continue until the ANC reaches greater than 0.5 times 10 to the 9th cells per liter?
So I agree with you for maintaining the antibiotic until the ANC recovers. My question to you is, why? Or any thoughts for why you would have to wait until the counts recover? Why couldn't we just stop them right now?
There was no pathogen identified.
Fantastic. Strong work. And I agree with the group. And this is an important concept to keep in our mind, and actually an area of high research interest in terms of de-escalation because of antibiotic stewardship efforts. So for AG, because no source could be readily identified and the patient stabilized, they should remain on cefepime until the ANC recovers. The reason is there's no source, there's no susceptibilities, there's concern that if you would de-escalate, the patient could again become, could decompensate, and you could see a worsening of their care. This highlights that patients can be on these antibiotics for weeks. What's important to know for AG is we had no source. However, there's a lot of emerging data that if you do have an identified source, you can treat for the traditional empiric allotted amount of time. So for example, say you had a patient who had hospital-acquired pneumonia. You would treat for that just as the IDSA guidelines would recommend for 7 days, or the new revision 5 to 7 days. And then essentially, once you treated that underlying infection, you could discuss with your team de-escalating. And I highlight here at the bottom, there's a lot of emerging data, and this is something to be aware of, that if you have a source, you treat the source, there actually is data to support de-escalating back to that fluoroquinolone prophylaxis until a count recovery. And what this highlights is a method to potentially attenuate some of this overuse of these broad spectrum antibiotics. However, the take-home message is if you don't have a source, it's often very difficult and may not be appropriate to de-escalate. So strong work, everyone. And this really highlights with our laboratory and initial assessment, what making sure we get all the right cultures before antibiotics is important because it allows us to guide our therapy. Strong work. So, using that, let's shift focus and go to our fourth patient case, which is DD. So he's a 30-year-old male who's diagnosed with acute lymphocytic leukemia, or ALL, which is Philadelphia positive. Again, you would not need to know any of these more hematology disease state focused things for my portion of the exam. I'm focusing more on the febrile neutropenia management. So he's admitted to the unit, he's being treated with induction chemotherapy, so we expect his counts to become low for a long period of time, so prolonged and profound neutropenia. On day 10, the patient spikes a fever, his counts are listed there, blood cultures are drawn appropriately, physical assessment shows no readily identifiable source of infection, and he started on cefepime 2 grams Q8, which is right in line with our experiences thus far and what the evidence recommends. So today is April 13, day 3 of cefepime, and DD is still intermittently febrile though, but otherwise he's stable in terms of vital signs and oxygenation. Cultures remain no growth to date. My question or challenge to the group is, what changes would you recommend to DD's febrile neutropenia regimen based on these persistent fevers at day 3? Give everybody about a minute to review this. And for those following along, we're on slide 28. All right, everyone, in the interest of time, would anyone like to volunteer an answer?
Just name all these things.
Should we just continue therapy since it's clinically stable?
No.
Excellent. I completely agree. Hold the course for DD. There's no need to panic yet. Yes, it is technically a fever of unknown origin. However, what's important to know, particularly about these leukemia and lymphoma patients, is there are a lot of various sources that could be causing this febrile event. But at this time, because the patient's clinically stable, we don't need to change the antibiotic. Now, that doesn't mean our work is done. This unexplained persistent fever does continue to warrant further assessment of sources of infection. And this is when we should be repeating blood cultures, repeating physical assessment, considering if the patient has an abdominal source, a pulmonary source, is their line red and warm to the touch. Fevers trigger us to continue our evaluation to try and find a new source. But I completely agree, we don't need to make modification of the initial therapy yet at day 3. And that is a little bit of a cliff note, because we'll talk about what happens once you get further out and you remain persistently febrile. So strong work, everyone. So let's shift over to case number 5, which is our patient SJ. So SJ is a relapsed refractory multiple myeloma patient admitted through the ER for 3 days history of malaise and fever. So unfortunately, SJ has been at home, not been feeling well, and he's been sick for 3 days and is only now really getting that medical attention. So he was recently treated with daratumumab, lenalidomide, and dexamethasone, which is a regimen for multiple myeloma. I have his counts listed there. His creatinine clearance is 70, so his renal function is all right currently. But he does have a reported fever of 39 degrees Celsius, which is a pretty significant fever. Blood cultures were collected appropriately. Again, collected appropriately. They were collected before antibiotics were given. Very important to highlight, because once you give antibiotics, the blood cultures essentially become more difficult to interpret or grow an organism. Physical assessment reveals no active source of infection, and he was started on cefepime 2 gram Q8. The following morning, he arrives under unit, and he continues to be febrile. Additionally, he's tachycardic, hypotensive, and he's not oxygenated well. A rapid response is called, and SJ is admitted to the medical ICU. So SJ is not doing well clinically. So I have listed here his lab work as he's transferred to the medical ICU. As he's transferred to the medical ICU. As he's being transferred, the ICU intern asked for recommendations on optimizing his febrile neutropenia regimen, since the cefepime alone does not seem to be working. I've listed a lot of information here. I'll give everyone 3 minutes to read through this, and then we'll ask for some volunteers on what changes you would recommend in terms of antibiotics to help treat SJ's decompensating stats. All right, everyone. Any volunteers for how we want to make some changes to the antibiotic regimen to help stabilize SJ? How about group number 21? Is group 21 with us today?
Yeah, we're still discussing.
Okay. Well, what in the interest of time, what are you discussing real quick? Let's talk about that part. What are you guys thinking about or considering?
Well, we're still trying to figure out if we should add another agent due to the pending cultures.
Oh, fantastic question. Fantastic question. And I apologize that we can't allow for more discussion due to running up on the clock here, but I like the way the group is thinking. And the reason we need to start thinking about that is SJ's not doing well, right? SJ is becoming clinically unstable. We are seeing that hemodynamic decompensation on current monotherapy with an anti-pseudomonal agent, ergocefepine. What are we looking at clinically? Sepsis. We're looking at sepsis because his blood pressure is falling. He's needing to go to the ICU. Additionally, if we look back at his labs, once again, you can see that he's developing an acute kidney injury. This is due to a multitude of factors, but again, sepsis could be driving that process. As his blood pressure falls, blood is going to be diverted from the kidneys, which can cause a pre-renal ischemia, which could cause some changes in their renal function. Additionally, I would not expect the group to know this for a test or relate to this lecture at all, but I do want to highlight that the patient is intubated now. That can be seen here with the vitals. The patient is actually on the ventilator. And so patients who are on the vent, you can almost always associate with being more critically ill. So due to this acute decompensation, with inadequate antimicrobial coverage, one of the things we need to consider is, do we need to broaden coverage, right? Right now, we're not covering any MRSA organisms, or we're really not covering anaerobes as well, right? We're using cefepime, which doesn't have the greatest anaerobic coverage. Therefore, considering broadening to add vancomycin may be of value, and it's probably what your groups were discussing. Additionally, in terms of gram-negatives, we have to consider, since he's critically ill now, could the patient have one of these multi-drug resistant or more resistant organisms, such as KPCs, ESBLs? Again, SJ's been out there and been sick for a while, but he's had some contact with the healthcare system, and it becomes one of these scenarios where the more critically ill you become, the more agents we start to throw at the patient to help stabilize them. So some things to consider in terms of the cefepime, we got to cover for anaerobes. He's crashing, we're not covering for anaerobes, we don't have a clear source, we got to expand coverage. Things we could consider are switching the cefepime to Zosyn, Zosyn having better anaerobic coverage. Additionally, you could keep the cefepime and you could add flagyl, which will add some of that anaerobic coverage, but it would require us to dose adjust the cefepime. Additionally, if the patient is concerned, if the medical team is concerned for multi-drug resistant organisms, again, relying on your antibiogram, knowing your unit. If you're at a hospital that has a high precedent of KPC organisms, maybe you do want to consider switching. Maybe you want to consider escalating therapy more quickly due to that risk. Again, the patient is getting critically ill, their life is in peril. We have to make sure their antibiotic coverage is broadened at this point, because even though we consider it broad, cefepime broad versus ceftriaxone or amoxicillin, we can make our coverage even broader yet because we have no discernible source of infection and our patient is critically ill. I would recommend for this patient, adding vancomycin is a must. Given the growing presence of MRSA infection, and also this patient essentially has sepsis, so he meets one of our criteria, it's time to add vancomycin using pharmacokinetic monitoring, targeting a trough of at least 15 to 20. I've put some recommendations there in terms of dosing. Again, would be based on your pharmacokinetic calculations and as well as institution practices. We'll target a trough of 15 to 20 or using the AUC monitoring depending on your institutional practice. In terms of the gram-negative component, since this patient is decompensating, I think while the conversation is had about whether you need to escalate to meropenem or Abicaz or one of these new multi-drug resistant antibiotics, at this point, because he's decompensating so quickly, getting an aminoglycoside on board now is definitely appropriate. Now, we're in a balancing act though, right? You have an acute kidney injury brewing, and we know that aminoglycoside can cause nephrotoxicity. So therapeutic drug monitoring is going to be critically important, but is necessary because their patient is acutely decompensating. I did put a throw out here that it's important to note with that therapeutic drug monitoring, you'd be doing traditional peaks and troughs. This patient would not be a candidate for the once daily aminoglycoside dosing that I'm sure you discussed in your pharmacokinetic lectures. Because the patient has a brewing AKI and is critically ill, traditional peaks and trough calculations would be more appropriate. So essentially for SJ, we need to broaden our coverage to make sure that we can stabilize the patient. And so let's say we did that. Let's say we added vancomycin and we actually eventually escalated to meropenem therapy. We gave a dose of gentamicin, but ID got on board, recommended stopping the gentamicin due to the AKI, broaden our coverage with meropenem, and 48 hours later, SJ continues to be persistently febrile. but he's stabilized, which is good news. Therefore, SJ continues on his regimen. However, after 5 days of therapy, and remember, 5 days after effective therapy of meropenem bank, that's 3 days before that. So we're packing 3 days before he came into the hospital, probably a day or two of the initial cefepime, and then 5 days of this broadened antibiotic coverage. We're now approaching really 8 to maybe 9 days of antibiotic therapy, and SJ is still febrile and profoundly neutropenic. The question remains, what other infectious organisms should be considered at this time? And in the interest of time, we'll use that as a cliffhanger. There's probably a fungus among us, and we need to consider in patients who are persistently febrile despite antibiotics for an extended period of time, which generally 5 days is the threshold, could there be a fungal infection? Why? If we're treating with antibiotics for 5 days and there's no response, this is when we need to think of other causative organisms. Obviously, bacterial organisms are of high concern due to their ability to proliferate and reproduce quickly. However, fungal organisms can often be slower growing. And this is why when you have patients who are on effective antibiotics for an extended period of time, at this point, we need to start considering fungal infections as a source. We'll delay the details of that conversation until we touch base on March 18th. There's a pre-class lecture for that, and I look forward to continuing that discussion with the group. So some take-home messages in our final few moments. We've talked about a lot of information, and some really key take-home points. Cancer patients with febrile neutropenia is a very serious condition. However, as pharmacists, we can be critical players at the table to help stratify patients and identify optimal treatment strategies. We can use techniques to classify them as high risk or low risk, and additionally, use information based on the anticipated duration and depth of neutropenia to guide our therapy. High-risk patients, which are generally, as a rule of thumb, going to be your patients who have leukemias, patients who have very critically ill status, such as sepsis at presentation, or patients with high comorbidities. They're going to get into the hospital and receive IV antibiotics. Versus those patients who are more stabilized and can receive outpatient therapy with oral agents with fluoroquinolones. If patients are admitted to the hospital, they're almost unanimously across the board going to get an anti-pseudomonal monotherapy as their baseline therapy. As we discussed, vancomycin should not be empirically used in every single case of febrile neutropenia. We need to use our brains and really think about the guidelines and really personalize our regimen for our patient using those risk factors for when it might be appropriate based on a source of infection and concern for gram-positive organisms. As we've discussed, the duration of antibiotic therapy is often going to be dictated by our ability to find a source and based on that treat the infection appropriately. If we're unable to do so, we're going to have to treat at least until ANC is greater than 500. And some institutions use a higher threshold, but for this presentation and for our questions, 500 will be our threshold. Additionally, one of the things to kind of wrap up, in our second case, we discussed that myeloid growth factors can be prophylactically used in high-risk patients. Again, there is a list of that on the NCCN guidelines that I would refer the group to. For the purposes of the test, we would call out if an agent was high risk for febrile neutropenia. Again, cueing you in that this would be something you need to consider. When you're in clinical practice, if you have a question about whether a regimen is high risk versus low risk, phone a friend. Always reach out to your fellow oncology pharmacists. I'm sure they would always be happy to talk you through the case. For patients who clinically decompensate on initial therapy, despite appropriate antimicrobials, you do need to consider broadening coverage. We want to prevent patients from getting critically ill, which can ultimately lead to mortality. And finally, for patients who persistently febrile 4 to 7 days after appropriate antimicrobial therapy, 5 days is your threshold to keep in your mind. This is when you need to start thinking about the fungus that might be among us. All right, everyone. I really appreciate everyone's time today, and I want to give serious kudos to the group. Excellent questions, excellent participation. I think we had some really good discussions. Does anyone have any comments, questions, queries, anything that I can help to clear up at this time? All right, since we're hitting the 11 o'clock hour, I really again want to thank everyone. I have listed here my email. So if you do have questions as you review this for the test or when you're reviewing this at home, my email is bjandrick@geisinger.edu. Please don't hesitate to reach out to myself via email. Additionally, if you reach out, you can always include, and I would encourage you to include Dr. Clemens as well. But I would be happy to take any of your questions and help to clarify any of these issues. Otherwise, we really appreciate everyone's attention, and I hope everyone has a great weekend. We'll talk soon.